Welcome to the Lumbar Spine Pre-Op Patient Education class. My name is Sarah Hewitt, and I'm a nurse here and your care coordinator. I will be joined by Dee Dee Decker, one of our occupational therapists. Patient and visitor information. We ask that any visitors not enter the hospital if they have any cold or flu-like symptoms. Our main entrance doors open at 5 a.m. and they close at 8 p.m. That being said, for you when you're coming in for surgery, the main entrance doors will be open. And if you have any visitors that are arriving before 5 a.m. or leaving after 8 p.m., they will have to enter and exit through the ER entrance. You are allowed to have 2 visitors here at the hospital during your surgery, and only one of them can come back to the same day surgery area once we get you prepped and ready. And when you go back for surgery, then they'll go back out into the waiting room. Once you get admitted to the hospital, if you're spending the night, you can have as many visitors as you want. There are no restrictions. Your one coach can spend the night with you if you desire, and we do ask that your coach wear their coach button, which is right here. And this coach button allows us to know that we're okay to talk with them and that they're allowed to be roaming the hospital at midnight if they are here with you. We do have some class objectives. First, I want to make sure that you understand your procedure, what to expect during your hospital stay, the role of your coach. We'll talk about pain management, what physical and occupational therapy we'll be doing while you're here at the hospital, the expectations we have for you at home, the discharge planning, and the big purpose of this class is to ease your anxiety and answer any questions that you might have. The role of the care coordinator, myself, is to help teach the pre-op education class. I am here Monday through Friday, so I'll be doing daily rounds. I'm your advocate, so I want to make sure that you're having a good experience, and we ensure that you have a smooth discharge. Each morning we'll meet with your nurse and our case manager, so if there's anything that you need prior to discharge, we'll make sure we have that arranged. Also, you will be receiving follow-up text messages and reminders. You will be admitted onto our 4th floor. It's a dedicated unit, our ortho spine floor. It's located on the 4th floor. There'll be private rooms, and our staff went through training so they know how to take care of patients who are having spine surgery. This is a picture of our rehab room. If you can see in the picture, there is a tub shower combo, and our occupational therapists really like for you to have a shower bench where you see in the tub where it's extending over that tub wall, so you can sit on the outside of the tub, swing your legs over, and you have a place to sit. And of course you can stand for your shower, but you may not have the endurance to stand up for your entire shower. Also, we do have a practice set of stairs at the hospital that we can practice with you if you have stairs at home before you go home. A little bit of your spine anatomy. Your spine is made up of 33 vertebrae. 24 of them are separated by the spongy disc, and you have 5 sections. You've got your cervical, your thoracic, your lumbar, your sacrum, and your coccyx. And I want to go over some of the landmark sites on your spine. So this is the lumbar spine. You've got your vertebrae, your bones, you've got your spongy discs. That's the part that goes bad for a lot of patients. That's on the front side of your body. On the back side, you've got this bone right here. This is called the spinous process. And on each side, that is called the lamina. And if you go down the center there, that is your spinal canal, and that's where your spinal cord is. I will have another one so you can kind of see the spinal cord. So the spinal cord runs through there, and then you have your nerve roots that branch off at each level. Also, we'll be talking about this hole right here where the nerve root comes out. This is called the foramen, and a lot of times we're going to clean that out and get those bone spurs off. But those are the big landmarks of your lumbar spine. Some indications for spine surgery: degenerative disc disease. That is actually normal body wear and tear of those discs. Over time, they start to shrink, they dehydrate, and they can collapse. And that causes some back pain, neck pain, leg pain, or arm pain. This can lead to arthritis, disc herniation, or spinal stenosis. In the picture, you will see some lumbar disc herniation. On the picture on the left side, that is a normal lumbar. That's what your back should look like. The big white line going down, that is your spinal cord, and you can see where the discs are. They're where they should be. If you look to the picture on the right-hand side, you can see where that disc has bulged out and it's pushing into that spinal canal. Spinal stenosis is a narrowing of the spinal canal, and that causes a lot of pain, numbness, tingling, burning, weakness, and loss of muscle control. It can also cause you the inability to walk more than just short distances. So if you were to have to park far out in a parking lot, you may have to stop halfway to your destination, let your back rest a minute before you can start walking again. And that is from that spinal stenosis. In this picture, you can see between the L4 and the L5, that spinal stenosis is pretty bad. It looks like it's cutting off that spinal cord, but it's just so compressed that you can't even see it. Radiculopathy, that is a fancy word for compression of the nerve or nerves. This causes pain, numbness, tingling, weakness along the course of that nerve. Myelopathy, functional disturbances of the spinal cord rather than the nerves. It's not always accompanied by pain, but a lot of times you are having pain because there is some nerve involvement. This will come with tingling, weakness. You could have some bowel or bladder problems, so some incontinence, lack of fine motor control, dexterity with your walking. You could have headaches and these electric shocks. When your spinal cord is getting pinched, you might get these electric shocks going down your arms or your legs. Spondylosis, fancy word for arthritis of your spine. This typically happens in the facet joints. So over time, just kind of if you think of a knee, there's cartilage between those vertebrae. And over time, wear and tear of that cartilage wears off and bone spurs can form. And so you might start having some grinding and crunching in your back. You may not have that range of motion, and that could be due to those facet joints having some arthritis. Spondylolisthesis, this is where the vertebrae slides forward over the bone below it. It is very common in the lumbar spine. It can be a slow or rapidly progressing problem, and you have a lot of lower back pain, numbness, tingling, and weakness down the legs. In this picture, you see the same person when they're laying down, that L3, L4, that spinal cord is getting a little bit pinched, but when they stand up, that L3 slides over the L4, further pinching off that spinal cord. We do have some goals for surgery. Number one, we want to get the pressure off the nerves, get the pressure off the spinal cord, ultimately lessen your pain and get you back doing the things you enjoy. So in order to do that, we may have to do a laminectomy, and that is removing a portion of that lamina, and it depends on the issue that you're having. They can remove the entire lamina or just part of it. So in the picture, you can see a full laminectomy or what we call a hemilaminectomy. Some people are worried that there is nothing protecting the spinal cord, but rest assured, you've got lots of ligaments and muscle, and your spinal cord is perfectly safe if we do have to remove the lamina. And this is a lot of times done in conjunction with a lumbar fusion. Foraminotomy, this is that hole, I call it the Roto-Rooter procedure. It's where that nerve root comes out. We're going to shave around that hole and give that nerve some more room to move so it's not pinched. Facetectomy, that's between those two joints. So let me show you that real quick. So on here, your facet joints are where each vertebrae meet. And so right there is where the cartilage wears off and those bone spurs can form. So we will shave off those facet areas if needed, and that will give that range of motion back into your back. Now, one thing, if we are doing a fusion, which we're going to talk about in just a bit, you won't have that mobility back in the back, but what you will have is the pressure off the nerves and potentially the spinal cord where it's going into. Lumbar discectomy. So this is removing the entire disc to take the pressure off the nerves and or spinal cord. Just know a microdiscectomy is a minimally invasive procedure that just removes part of the disc. But if you're having a full lumbar fusion, then we will remove the entire disc. We also can do a lumbar disc replacement, and that is designed so you get that normal movement back into your lumbar spine. Now, not all patients will qualify for this. You usually are 55 years or younger, you have minimal effects of osteoporosis, and when we do this surgery, the incision is going to be made on the front. If this is something that you're able to get, your surgeon will definitely give you that option. We do many different lumbar fusions. You can accomplish very similar things by different approaches. So we will be going through all of these, but there's a transforaminal lumbar interbody fusion, minimally invasive transforaminal lumbar interbody fusion, anterior lumbar interbody fusion, a direct or extreme lateral interbody fusion, oblique lumbar interbody fusion, and an SI joint fusion. And so we will go through all of those. But before we do that, what is a fusion? A fusion is where we are fusing 2 or more vertebrae to become a solid piece of bone. We will take out the entire disc and we'll replace it with bone graft material and a cage. That cage is also called a spacer. So if you've heard the word spacer, you've heard the word cage, we're talking about the same thing. With the bone graft, we will use your own bone potentially and synthetic bone. Also, we sometimes will use your own bone marrow, mix it in with that bone mixture. And if we don't have enough of your own bone, we will use cadaver bone. The types of hardware we use is typically made with titanium. We use rods, plates, and screws. And most cages, yes, are made from titanium, and they are safe for MRI. So if you do need an MRI in the future, you'll be able to have one. We have robotic navigation, and what this is you will have a CT scan before your surgery, and this helps your surgeon precisely plan where the screw placement will be. For the fusion, you'll have smaller incisions and reduction in how much radiation you're exposed to during the procedure. One of our newer procedures using augmented reality, it's where your surgeon can see your anatomy in a 3D vision, which is really neat. Currently, we're using this for our lumbar surgeries if your surgeon wants to use it, but it's just enhancing that precision and outcomes. Now going over the different lumbar fusions, the transforaminal lumbar interbody fusion, the TLIF or the MIS TLIF. The MIS part is the minimally invasive. So if your surgeon performs that procedure, that just means you're going to have 2 smaller incisions on either side of your vertebrae versus 1 bigger incision. And with the lumbar fusion, the TLIF, you will have screws and rods placed. And if you see in the picture, you can see where the screws go into the vertebral body, and then the spacer or cage goes into the disc space. So I'm going to show you what that will look like. So this is the TLIF. So you've got your vertebrae, your disc space, your vertebrae. This is where that cage goes. And you can't really see it in the video, but there is a hole inside that cage, and that's where they put the synthetic bone material, your own bone, your bone marrow. They'll mix all that up, and then they will pack the disc area also around that with some more bone graft material. Now, if that's all we did, then your spine would just move all over the place. So we still have to fuse it keep it in place using screws and rods. So you'll have a 1-level fusion, you'll have at least 4 screws and 2 rods. And that's what it will look like. In this picture, you will see on the left-hand side a successful lumbar fusion. There are some markers that are built into the cage. So if you were to move away, have an x-ray in the future, you had the hardware removed, but you of course still have that cage in there, they can see, that radiologist can see that you had a surgical intervention for those vertebrae to fuse together. On the right-hand side, you can see where that bone graft is still trying to grow. There's still some black on either side of that. And so that is a fairly newer lumbar fusion where that bone is still growing. Anterior lumbar interbody fusion, also known as the ALIF. This is where they go on the front of your abdomen to do the procedure. We use synthetic bone material, and just so you're aware, if you're a male, you may have some testicle swelling or some swelling just in general in the lower groin area from the procedure, and I want to show you what the ALIF procedure looks like. There are 2 ways they can do the ALIF procedure. And they can do one where the plate is on the outside, so you've got the cage with the plate on the outside, or you've got this one where you've got screws that are into the vertebrae where it lays more flush. So it just depends on which part of the vertebrae we are doing the surgery on, whether or not you're going to have a plate or if it's going to be more flush. Oblique lumbar interbody fusion, that is still on the front of the abdomen, but we go more to the side. And we do synthetic bone graft material, and the type of cage we use is very similar to the A-lift cage. We do a direct lateral or extreme lateral interbody fusion, a D-lift or an X-lift. This is where the incision is made more on the flank, more on the side. A lot of times it is on the left side, but you could have it on the right side, but a lot of times it is on the left side. And they will put synthetic bone graft material in, and you may have some left leg pain, so increased left leg pain, and that left leg could be weaker for several days, several days after the procedure. So don't be alarmed if that happens, and I want to show you what that looks like. So I just have the cage for the D-lift, but this is what the shape is of the D-lift. So it's a big, round, more oblong, and that's that hole I was talking about earlier. That's where they put that bone graft material in. So for the D-lift, the X-lift, this will be synthetic bone inside this cage. We also will do something called a posterior lateral arthrodesis, and this is where we lay bone graft material on the back side of the vertebrae. So on this model, so you may or may not have screws or rods back here, but they'll lay bone graft material just on the outer side, and that's going to fuse with hard solid bone on here. And then if you're having a fusion inside here, which most likely you are, they will fuse, these vertebrae will be fused as well. SI joint fusion, this is where your sacrum and your pelvic bone are unstable. They have instability. So you could have something called a SI joint fusion, and they will fuse the sacrum to the pelvic bone. They usually use 3 dowels. They can do just one side, or they can do both sides. It just depends on how much instability you have. Risk factors with spine surgery. So you're at risk for spinal cord and nerve injury. If you can see in this model, we have your spinal cord and nerves, and your surgeon is cleaning things up around there, and so there's always that risk they could nick the spinal cord or nick the nerve. Small risk of that happening. And to ease your anxiety, we do have the neuromonitoring wires. And with the neuromonitoring wires, these are little sticky wires that they will put on your wrist and put down on your ankles. So throughout the procedure, these will be placed before the procedure. And then throughout the procedure, they will have visualization of those nerves. Also, when you wake up, and this happens when you're asleep. So when you're asleep, they put these tiny little baby needles in your head, could put them down on your wrists and on your legs. So you may wake up with little bruises or little drops of blood places. Just know that is part of the neuromonitoring during your surgery. Vascular injury, so blood vessels are running alongside some of those nerves. So there is a chance they could nick a blood vessel, but again, that is a small chance of it happening. Non-union. So this is talking about those of you who are having a fusion. So our goal with the fusion is to fuse those 2 vertebrae together to become a solid piece of bone. Sometimes that does not happen. There's several risk factors that can accompany the reason that doesn't happen. So number 1 thing is smoking. Smoking constricts blood vessels, and the nicotine softens bone. And so we're trying to grow bone, so we don't want that bone to be softened. Some insurance companies won't even let you have surgery until you're smoke-free for a month plus. So it is very important to quit smoking. Our goal for you is to stop smoking at least 1 week, if insurance doesn't require longer, and for at least 6 weeks after surgery to help with that fusion and the healing. We have often found that smokers have more pain than non-smokers, so that is also a plus to quit smoking. Obesity, definitely, if you're having work done on your lumbar spine takes on a lot of extra pressure. So even getting a few pounds off will take that weight off the lumbar spine and help with your pain and your healing. Osteoporosis, you don't have control over having osteoporosis, but what osteoporosis is where your bone isn't as dense, and so that bone will take longer for it to grow. If you have diabetes, that overload of sugar in your body can slow down the healing. And then malnutrition. Make sure you're eating a well-balanced diet. Lots of protein and lots of vegetables are important for your wound healing. If your surgeon is worried about your bone growing, they can order something called a bone stimulator, which you can see on the slide. And it kind of looks like a TENS unit. If you've ever seen a TENS unit before, it has little sticky wires and they'll be placed near the vertebrae. They'll be placed on either side. And it just sends these little impulses to the bone and it tells it to grow. So if you do need to get that, then your surgeon will have the rep bring that to your house once you're discharged from the hospital. The next thing is adjacent segment collapse. So this part is where you have friends and you tell them, I'm having spine surgery. And they're like, oh no, once you have one spine surgery, you're going to have one after the other after the other. So to an extent, they're not lying to you, but they're also not 100% accurate because everybody is having back surgery for a different reason. You could have some degeneration of your disc, or you could have had a fall or a car accident, and just that one section of your vertebrae has gone bad. So why that is said is when we start fusing vertebrae together, instead of each individual one moving on its own, we fuse them. So this whole section is now becoming one solid piece of bone. So over time, wear and tear, the disc above it, the disc below it could start taking on that extra strain and start to go bad. Your surgeon can normally tell you what the other quality of your discs are and kind of predict, in the future if you'll have to have more surgery. I mean, could it be a year, 5 years, 10 years, or hopefully never have to have more spine surgery, but just know that would be the reason for needing some more spine surgery. The other thing is a dural tear. So your spinal cord is surrounded by a fluid-filled sac called the dura. And when they're doing, especially when they're doing the laminectomy, they can, where that dura is, those bone spurs from the lamina just are wearing and tearing at that dura. So when they go to clean that off, it's like tissue paper and it tears. So your surgeon will repair it either with a suture or a patch. And depending on the size of the tear, they may have you on bed rest. Bed rest meaning you will be in the bed. You'll be laying flat because what happens is that will take the pressure off that tear. So if you go to sit up, there's pressure that's trying to get that spinal fluid up to your head. So we'll want you to lay flat. It depends on the size of the tear, everything like those specific things. It could just be overnight. That next morning we'll let you get up and start working with therapy. You're allowed to roll side to side. That is perfectly fine. It's just the sitting up we don't want you to do. They will sometimes let you sit up just a little bit to eat your meals, but then you go right back down to take that pressure off the tear. Infection, we don't plan on you having infection, but we do want you to know what to look for. So if you start running a fever, having increased pain, swelling, redness, heat, any abnormal drainage like any green, yellow, cloudy, smelly drainage, or if you're having drainage lasting over a week, you definitely want to let your surgeon know. Be sure to wash your hands before touching your incision. We prefer your pets not to sleep in the bed with you. We don't want your pets licking your incision. If you don't have the heart to kick your pets out of the bed, give them their own covers to the foot of the bed, and you may want to wash your sheets more frequently. We do want you to wash your sheets at least once a week because us as humans are also covered with bacteria and we're constantly shedding our skin cells. So at least once a week, put fresh bed sheets on your bed. CHG bathing. This is going to help prevent infection. It's going to kill that bacteria off your skin. During the hospital stay, we will be using some CHG wipes, and you will learn about the CHG wipes before your surgery later on in the presentation. But these are the CHG wipes. There are 6 wipes in here, and further on the presentation, we will show you how to use them, but you'll be using the wipes during your hospital stay. And when you go home, you will be using the CHG solution and the sponge. So how you use this is when you're in the shower, you're going to suds up really good. You will avoid your face, your hair, your private areas. Make sure you're not getting it in your eyes. You'll suds up, you'll let it sit on your skin for 2 minutes, and then you'll rinse it off. Be sure you're not directly scrubbing over your incision, but scrub around it and allow the water, the soapy water, to run over it. Make sure you're drying off with a freshly washed towel. Don't be putting any lotions, perfumes, anything like that on the skin because that'll deactivate the CHG from working. Bathing and incision care. So like we were saying, you are allowed to shower. You can get the incision wet once the initial dressing comes off. The surgical dressing is usually removed 2 to 5 days after your surgery. We will talk to you about that after your surgery is over with, so you'll know exactly when to take that dressing off. Once your surgical dressing is removed, you can start doing daily dressing changes, get the incision wet. You will put a fresh dressing on every day until there's no more drainage. You want to look at the bandage, the dressing for the drainage, don't look at the incision. So once that dressing comes off clean, like you put it on the night before, then you are good to keep it off and leave it open to air. We do not want you to put any ointments or peroxide on that incision. If you are concerned for infection, you are calling your surgeon right away. Only showers, no tub baths, no swimming, no hot tubs, no submerging underwater until your incision is completely healed. And again, once you're done, so you'll use the CHG wash for 7 days post-operatively, and then after that, you'll go to your normal soap and water. Your incision will be sealed with Steri-Strips and or Dermabond, which is a purple glue. Sometimes the surgeon will use something called a Dermabond Preno. And what that is, it's like a Steri-Strip, but more of like a mesh, kind of like a window screen, and they'll paint the Dermabond over top of it, and it gives it that extra stability, a little bit stronger. With the Dermabond and the Steri-Strips, we do not want you to remove those. Those will all naturally fall off on their own. Sometimes your surgeons will use sutures or staples depending on where the incision is, and those would need to be removed at one of your follow-up appointments. Sometimes they will use a small vacuum device to help with wound closure and help it heal a little bit faster. If you do have one of those, we'll talk in more detail after your surgery. Average length of time for surgery, we have all those different procedures. Your SI joint fusion will take about 40 minutes. A microdiscectomy is an hour. Lumbar laminectomy, 1 to 2 hours. It depends on how many levels you have being worked on. The A-lift and O-lift will be 1 to 1.5 hours. The D-lift and the X-lift will also be 1 to 1.5 hours. A lumbar disc replacement, 1 to 1.5 hours. The minimally invasive T-lift is about 2 hours. The traditional T-lift is 2 to 2.5 hours. And if you do have any sort of robotic case, then it will add a little extra time to that surgical time. Now this time is just the time that your surgeon is in there doing the procedure. So add another 45 minutes to this time, and that's how long you'll be in the operating room. Average length of stay. For a lumbar laminectomy, you could go home outpatient or stay 1 night. Same thing with a microdiscectomy. The SI joint fusion, also outpatient or 1 night. Minimally invasive lumbar fusion, that is outpatient to 1 night. The D-lift, the X-lift, and the O-lift is 1 to 2 nights. The A-lift and T-lift are 1 to 3 nights, and the lumbar disc replacement is 1 to 2 nights. For spine healing times, with the lumbar disc replacement, it's basically the healing of that incision. You do want to be cautious for about 6 weeks. Same thing with the laminectomy. For a microdiscectomy, you want to be real cautious for 6 weeks. It's kind of like patching a tire, so you want to be real careful. You don't want that tire to blow out again. A lumbar fusion, a good 3 to 6 months it takes for that bone to start growing. It can take up to a complete year for that whole lumbar disc space to fuse. Returning back to work. So this depends greatly on what you do for work and all sorts of factors. Your surgeon will definitely let you know, but just as a rule of thumb, light duty is 2 to 4 weeks. Heavy duty is 3 to 4 months. Of course, make sure you contact your surgeon and see your surgeon before you try to go back to work or do any extracurricular activities, and definitely no driving until you're cleared by your surgeon. So rule of thumb for driving is we do like you to be off your pain medicine during the day, good hand strength, good feet strength, feel safe to drive, and ultimately get permission from your surgeon. I know we've given you a lot of information so far, so this is a great time if you want to pause the video and take a break. Dee Dee will be on next, and she will continue talking about how to get prepared for your spine surgery and what to expect after.
Welcome back. My name is Dee Dee and I am the lead occupational therapist here at Stonecrest. And now we're going to talk about how to prepare for your surgery. Your guidebook is filled with wonderful tidbits of information that we do go over here in class, so if you ever have any questions, feel free to reference your guidebook. We also encourage you to bring your guidebook with you to your surgery and to any surgeon appointment you might have. We also ask that you prepare your home for this surgery. So make sure you put away anything that could be a tripping hazard and get yourself a supportive chair with armrests to make it easy to stand up and sit back down as your recovery. Shop ahead, have some easy to prepare meals, and make sure you have somebody else cooking them for you. Try to have somebody there with you for the first week to help care for you as you recover. Speaking of that person, we like to call them your coach. Your coach is somebody we love here at Stonecrest because first off, they know your baseline. They know what you are like before pain medication and before anesthesia. So if something were to go wrong, they are probably going to notice before we will. Also, they don't have medication or anesthesia in their body, so they are going to help keep you accountable once you go home, because you might have a hard time remembering what we are telling you here at Stonecrest. Some things to note for your coach is that our visitor cafe is only open for breakfast and lunch. However, they are able to order dinner alongside you, the patient, from one of our dietary staff members. It will just be brought up to your room with your meal. Our newsletters, daily homework, and coach's checklist are things that Sarah or your nurse will review with you during your recovery here at Stonecrest. Our incentive pathway is our road to recovery. It is filled with check boxes that you will have to meet in order to discharge from the hospital. If you are taking any sort of medication that is prescribed by a doctor, such as Coumadin, Plavix, or Xarelto, we ask that you please talk to that prescribing doctor prior to stopping this medication. And they will have a better plan in place that they can reiterate to you as well as your surgeon. Tylenol is okay to take prior to your procedure. We just ask that if you take it the morning of surgery, you please tell your same-day surgery nurse that it was taken. Pre-admission testing is our hospital's way of preparing for your appointment. You will come and check in at the registration desk, and from there they will direct you to your pre-admission testing appointment. During that appointment, you will have lab work done and a few other different procedures depending on your surgeon. You will also meet with a hospitalist where they will discuss any medications you are taking as well as your past medical history. You also might have a consultation with an anesthesiologist. If you aren't able to, do not worry. We'll talk about anesthesia a little bit during this presentation, as well as you'll be able to meet with your anesthesiologist on the day of your surgery. If you take a GLP-1 drug, we ask that you stop taking it 8 days prior to surgery. This includes Ozempic, Wegovy, or Mounjaro. We also will test you for MSSA or MRSA. These are antibiotic-resistant bacteria that can live dormant in any of our bodies, but can cause a pretty nasty infection. If you test positive for either of these bacteria, we will send a prescription to your pharmacy of an ointment that you will put in your nostrils twice a day for 5 days leading up to surgery. Do not use this ointment the morning of your surgery, but please bring the used tube with you so we know that you did it. Other things that you can bring with you. This is a very long list, but I want to hit the highlights. Don't forget your insurance card or your ID. Also, if you have sleep apnea, please don't forget your CPAP or BiPAP machine. We ask that you bring comfortable, loose-fitting clothes to change into following your surgery, as well as slip-on shoes. We love shoes that have a back and ask that you do not wear Crocs or flip-flops as they can be fall hazards. Also, please, please, please protect your body from cuts, scrapes, scratches, all of the above, as this is something that can postpone your surgery. We ask that you take 2 extra strength Tylenols, which equals 1,000 milligrams, 3 times a day for 4 days leading up to your surgery. If you are taking any sort of pain medication that has acetaminophen in it, we ask that you do not take this extra Tylenol. We encourage good nutrition leading up to your surgery, eating lots of protein and leafy green vegetables, and reducing your sugar intake. ESR stands for Enhanced Surgical Recovery. It is the model we use for every surgery here at Stonecrest. There are a lot of benefits to ESR, but our favorite is increased patient satisfaction. The night before surgery, we want you to shower as normal and dry off with a clean towel. You will then wipe off with CHG wipes that are provided to you during pre-admission testing. We ask that you wait 1 hour following your shower to use these wipes, as they are very, very harsh, and we want to make sure your skin is dry. Please go to sleep with clean sheets that night, and do not shave your legs or neck before surgery. This is our model of how we want you to wipe off your body using that entire pack of wipes when you use them. Now, we ask that you don't eat anything after 11 p.m. the night before your surgery. However, you can drink clear liquids up until 2 hours prior to your arrival. At that 2-hour mark, you are going to drink this carbohydrate-rich drink. It will be the last thing you drink, and it will fill your body with electrolytes and carbs and prepare it for surgery. If you are diabetic, we will not give this to you in pre-admission testing. Instead, we ask that you drink something like Powerade Zero, Gatorade Zero, or Propel in order to give your body the electrolytes without the sugar. If you are taking GLP-1 drugs, you will not eat or drink anything for 12 hours before your surgery, and therefore will not be drinking this. We also ask that you do not wear deodorant to your surgery, as it is not compatible with those CHG wipes. Please do not take a shower the morning of your surgery, as the CHG wipes are still working. When you get here, you will check in to the registration desk, just like you did for your pre-admission testing appointment. Then they will take you back to our outpatient waiting room, where you will meet with our same-day surgery nurse. From there, she will take you back to the same-day surgery room and help you prepare for surgery. She will wipe you off yet again with more CHG wipes. She's also going to put a nasal antiseptic in both nostrils to kill bacteria for over 12 hours. From there, she will do a head-to-toe assessment to make sure that you are clear and free of any scrapes, skin tears, or cuts, and safe to have surgery on. She will also put on your TED hose and SCDs, start your IV, and give you any pre-op medication. She will also frequently ask you questions to verify your surgery, such as what is your birthday, what is your name, and what surgery are you having. You will then meet with an anesthesiologist. During your surgery, your coach is going to be waiting in the outpatient waiting room. Wi-Fi is available for them, as well as a TV tracker where they will be able to monitor your surgery. We ask that they turn on Wi-Fi calling and turn off spam blocker, as it will give them the best opportunity to answer a phone call from your surgeon following your surgery. It is important that if you have family or friends that are interested in keeping up to date with your surgery, they must have a passcode when they call our hospital. This passcode can be received from your coach or yourself the day of surgery. They also can follow along by using the Informer. This is our online text message system that we can send to any loved one who would like to keep up to date with your surgery. But please note, you must have your account number in order to sign up for this. You can receive this at the registration desk the morning of surgery or during your pre-admission testing appointment. After surgery, you are going to go to our post-anesthesia care unit, or our recovery room. Here, they will monitor your vitals and make sure that you are waking up safely from surgery, as well as keeping your pain under control. From there, you are going to admit to our orthopedic unit. How are you going to be feeling after surgery? You're probably going to be feeling pretty tired, and your stomach might be a little queasy. So we really encourage you to take lots of naps and begin with light foods that day of surgery. Please avoid any cheeseburgers. If you are having an ALIF procedure, you probably will begin with a liquid diet that your surgeon will advance as you progress. If you have a urinary catheter It will be removed either the same day of your surgery or the morning after. There are also some drains that you might have present. I'm going to show you one now. This is our hemovac drain. Most of our surgeons use this drain in order to help with the closure of your incision. If you are having a laminectomy, it will be removed post-op day 1. If you are having a lumbar fusion, it is typically removed post-op day 2. If you are having an MST lift, then you will not typically need one of these drains. This is George. He is our lead physical therapist. And if you see someone like him in those colored scrubs walking into your room, be prepared to do some work. Let's talk about physical therapy. So physical therapy cares about your functional mobility. That means getting in and out of bed, walking up and down the hallway, climbing and descending the amount of stairs needed to get in and out of your home, balance, and so much more. They are probably going to see you the same day of your surgery because we have a goal of getting you out of bed within 4 hours of arriving to our orthopedic floor. If you do not see them that night, then you will see them the next morning. Occupational therapy will also see you that next morning. We care about your functional skills, such as dressing, getting out of bed, getting on and off the toilet, and bathing. We are going to teach you how to do all of these activities of daily living while maintaining your spine precautions. Let's talk about spine precautions. We want you to follow the BLTs. No, that is not a sandwich. No bending, lifting, or twisting. You are not going to be able to perform this for 6 weeks following your procedure. We also want to make sure you don't lift anything more than a gallon of milk, have no jerky movements, no pushing or pulling, and please log roll whenever you get in and out of bed. If you are having an SI joint fusion, you are going to have precautions for 6 weeks as well. We want you to avoid any sort of strenuous activities, and your weight bearing is normally partial weight bearing. This means that you can only put a small amount of weight through that operative side that you had the SI joint fusion on. Typically, you will use crutches or a walker, and we want to make sure you are walking on an even surface. Please avoid going up and down the stairs, sitting or standing for long periods of time, and lifting anything over 10 pounds. With an SI joint fusion, we want you to sleep on your back or on your non-operative side with a pillow between your knees. Please avoid bringing one leg too far out in front of you or one too far away from the other. Let's talk about a few medical devices that you might see here at Stonecrest. You will all be attached to an IV pole. This is how a lot of your nurses will run medication into your body while you are here. You're also going to be attached to a vitals machine as well as a pulse oximeter. This little gadget attaches to your finger and measures the amount of oxygen in your blood as well as your heart rate. This is our pulse oximeter. This is our gait belt. We use this as therapists and nurses in order to safely hold you while you are walking or transferring to a chair or a toilet or climbing up and down the stairs. We want to make sure that we have a good hold on you in case you trip or fall. This also goes home with you, so we will teach your coach how to use it. These are SCDs. These attach to a machine at the end of your hospital bed and contract and inflate in order to pump blood up through your body and to your heart. It helps prevent any sort of blood clot or pulmonary embolism. Speaking of blood clot prevention, we also like to use these TED hose. These are compression stockings that do the same thing. You could wear these during your hospital stay and up to a week after you discharge home. These are a few lumbar braces that your physical therapist is going to fit you for if you are not already fitted in your surgeon's office. Typically, surgeons will ask that you wear these anytime you are out of bed. Occupational therapists will also review a few assistive devices with you that could be beneficial to you regaining your independence and performing all of your skills of daily living at home. Let's review a few of them. First and foremost, this is our long-handled sponge. It lets you wash your body from your head all the way to your toes and even your back without bending or twisting. This is our reacher. I have a lot of patients that like to use this for threading their underwear or pants and even removing their socks. They're able to get dressed without having to break any back precaution. This is our long-handled shoe horn. We love this because it allows you to get your shoes on independently. What we have you do is put this long-handled shoe horn in the heel of your shoe, and then you're able to guide your foot into it. This is our sock aid. We love our sock aid because it allows you to put on your socks independently. You will slide your socks over this, make sure they're taut. Be sure to also look at the knots here because we don't want you to put your socks over the knots. They can be scrunched as needed. Once the sock is on there, you'll toss it down to the floor, slide your foot in, and pull using these ropes. Pull and pull and pull until you feel like you can't pull anymore. Then keep pulling, and that will help you put your sock on. Finally, you'll see on the screen a bottom buddy. This is a great tool that you can get on Amazon and you can use to help wipe without twisting or bending too far. If you have any questions about the bottom buddy, be sure to ask your occupational therapist. Let's talk about a few other assistive devices that could be really beneficial once you discharge home. First and foremost, we love a shower chair. This is an easy solution to being able to shower independently once you are home. A shower can take a lot out of a person after a surgery, and we would rather you sit down when you feel tired than try to get out of the shower, trip, fall, and re-injure yourself. The walker could be used if you are having difficulty getting around or maintaining your balance. We will recommend a rolling walker here for you, and if you are unable to attain one or don't have one, we will be able to provide one for you here at the hospital with little to no cost. Finally, if you're having trouble getting all the way to your bathroom or you have a toilet that is low to the ground, the bedside commode or raised toilet seat could be beneficial once you go home. Let's talk about a few post-op exercises that we would like you to do during your stay here at the hospital and at home. Physical therapists will go over this with you while you are here at the hospital. First, we would like you to do some ankle pumps. We ask that you do about 20 to 30 every half hour that you are awake. We also want you to do some nerve glides. We want you to do about 5 sets of 10 throughout the day. So eventually you get to 50 per leg each day. You do not have to do these consecutively. Take rest breaks as you need. Walking is also so important. We love for you to get up and moving. It actually helps with your pain and stiffness, but we ask that you do not walk more than 2 miles a day for the first 6 weeks of your recovery. Finally, let's talk about our incentive spirometer. This incentive spirometer is what we give to everyone who has a surgery here at Stonecrest. It helps open up your lungs and prevent pneumonia. So what you are going to do is you are going to suck in through this tube 10 times every hour. You are going to measure the volume of your breath with this little green guy, trying to raise it up to your mark. We want you to do this 10 times every hour, followed by 2 good coughs. If you cannot do it 10 times consecutively, that is okay. Take rest breaks as needed. You will do this for 5 days following your surgery. Your daily homework, again, is gone over by Sarah, but a few things we want you to be prepared for is that we would like you out of bed for all of your meals. We also ask that you find a new sleeping position if you are a stomach sleeper. Sleeping on your side with a pillow between your legs might be more comfortable, or sleeping on your back. Another option is that you can always choose to sleep in a recliner instead of sleeping in bed. Whenever you do need to get in and out of bed, we ask that you log roll instead. If you don't know what that is or are confused, don't worry. Your physical and occupational therapist will teach you how to get in and out of bed properly. Take your time when resuming your daily activities. You are recovering from a major surgery, so you might not be able to get back to laundry, cleaning, vacuuming as soon as you would like. When you are staying here at Stonecrest, we ask that you follow our mantra, call, don't fall. You're going to be attached to a lot of different lines and tubes while you are in the hospital, and we do not want you to trip, cause a fall, and re-injure yourself. So please use that call button to call your nurse anytime you need to get up into a chair or onto the toilet. This is our pain scale. Everybody who comes into your room is going to ask you on a scale of 0 to 10, what is your pain level? This is how we make sure that your pain is managed well. We use a multimodal approach here at Stonecrest to our pain management, which means that we don't just use pain medication. In fact, ice is something that we like to use, as well as movement. A few items to note about pain management. You might be attached to a PCA pump, and that means you and only you are allowed to press the button to administer your pain. You are experiencing a different type of pain after this surgery, more of a surgical pain. Remember, we want you to take your pain medicine as prescribed. We would rather you intercept the pain rather than catch up to the pain. But if your pain medication is not being effective, please tell your nurse. Also know that your pain medicine, while scheduled, is typically ordered PRN or as needed. So you must ask your nurse in order to receive pain medicine. Finally, if you don't hear anything from me from this presentation, hear this. I do not see patients come back for infections or falls, but I do see them come back because they were not taking stool softeners and are constipated by taking these pain medications. Please find a stool softener that works for you so you can take it while you're on these pain medications. At Stonecrest, we know how beneficial cold therapy can be, and that's why all of our lumbar procedures will be given a polar cube. This is a giant ice machine that will attach via a Velcro strap to your back. Let's look inside. As you can see, there are 2 levels inside this container. You will fill up water to level 1 and then fill the rest of the way to level 2 with the ice. This attaches like so. You plug it in the back and then plug it into the wall in order to turn it on. We would like you to use this 24/7 for the first 72 hours after surgery. After those first 3 days, we would like you to wean it to about 20 minutes on, 20 minutes off, and by the end of the week, you will use it as needed. Please remember, we would like you to put some sort of barrier between your skin and this ice pack, as we do not want to cause a burn. You are able to apply heat to your affected area of your body for 15 minutes every hour. Please, though, do not place heat on your incision. Sometimes repositioning, getting up and walking can also help with the pain. But remember, we can't always make the pain go away completely. We want it to be tolerable. And again, if your pain is not being managed well or your pain medication is not effective, please contact your surgeon once you're home and contact your nurse here at the hospital. Sometimes nerve pain takes upwards of a year to fully recover. So take your time and recover gradually. Be patient. I know it can be frustrating, but I promise you will feel better in the end. Once you're home, please take your pain medication as prescribed. You will not get addicted to it. Your surgeon has given you the appropriate amount of pain medicine. You might also take some NSAIDs in order to help with the pain. This includes ibuprofen or Advil. Please do not take any other pain medication than the ones prescribed to you by your surgeon. When you go home, we ask that you use your primary pharmacy for all of your pain medication and other medication. However, know that some pain medication might be restricted. If you have any sort of issue with your pharmacy, please contact your surgeon. Your rolling walker, if it's required for you, will be delivered prior to going home, and make sure you have a ride ready to pick you up around lunchtime. Plan ahead for somebody to be at home with you to help care for you, as well as any pets you might have. Pets can unintentionally cause falls, so if you have a little one at home, try to put them away in a separate room until you are settled. Then slowly introduce them to you. Home health in a skilled nursing facility might be recommended by a therapist, but we know that you recover better at home. If you are recommended to go and receive home health or go to a skilled nursing facility, we will talk about that during your stay here. Your follow-up appointment is typically scheduled in 2 to 3 weeks, and if you are a workers' comp patient, please be in contact with your caseworker prior to surgery. Also, pick 1 day a week to track your recovery. This is a hard surgery, and you are going to have good days and bad days, highs and low. It will be much more encouraging if you pick 1 day a week to measure your progress over that entire week. If you feel like a decision is being made about you or without you, please tell us. This is your surgery and we want it to be as successful as possible, and we would love for you to be a part of the decision-making process. We also want to invite you to our reunion lunch. It happens once a quarter here in our medical office building. We spend time together and fellowship, as well as get to see your progress as team members, and it is just a wonderful time. If you come in contact with a wonderful staff member, you are always able to nominate them for the following awards. If you have an exceptional nurse, you can nominate them for the Daisy Award. The Rose Award is for other staff members such as therapists, EVS workers, or dietary staff members. And you can always nominate your surgeon for the Mid-Level or Physician Award. My Health One is our online patient portal that we use for all of the information here at the hospital, such as hospital bills, surgery information, as well as information regarding your hospital stay. We encourage you to create a login at myhealthone.com or tristarStonecrest.com. If you do take photography or videos during your stay here at Stonecrest, we ask that you receive verbal consent from anybody else in those videos prior to taking them. Your Care Pathway Survey, or your PROM survey, is how we measure your progress from before to after your surgery, upwards of a year. So we ask that you please fill out your survey if you have not already, and then expect to receive one at 6 weeks, 6 months, and a year after your surgery. You're also going to be getting a Press Ganey survey. This is our patient satisfaction survey. If you had a wonderful experience here at Stonecrest, we want to hear about it. If you did not have a wonderful experience here at Stonecrest, we also want to hear about it, because we do not know what we need to change without you sharing it with us. You can also review us on Google, Facebook, or Yelp. And thank you for attending spine class. I appreciate the time that you have spent with me today. And if you have any further questions, feel free to contact Sarah at the number below from 8 a.m. to 4 p.m. Monday through Friday. Thank you.